So thank you for the introduction, Sean. As you mentioned, I'm a gastroenterologist. I'm in a community-based practice, and I represent those of us who are at the front line of the diseases you heard about this morning, whether it's acid reflux, Barrett's esophagus. I'm going to talk a little bit about Barrett's esophagus with dysplasia and what that means, and of course, esophageal cancer. So today I'm going to talk about a little bit about the disease state. I think Dr. Woodward did a great job of explaining acid reflux and Barrett's and esophagus cancer. I'm going to talk about why patients even get it in the first place and why it's important and kind of what I say to patients so they can understand what's going on in their body. I'm also going to talk about the unmet need and how exactly EsoGuard essentially fills that need, especially for our patients and in my practice. And then finally, as Sean mentioned, I'm going to talk about how I interface with Lucid and with EsoGuard and how it really has changed completely the way I deliver healthcare. And more importantly, or just as importantly, how it's made me even more busy as a clinician, which is great for me and my patients. So we saw this slide earlier. This is the disease state. I'm going to go into a little bit more detail about it so we can get an understanding as to why it's so important to have a new tool to screen for precancer lesions. So we understand acid reflux. Dr. Woodworth really explained that well for us. And we know that acid reflux is one of the main risk factors for what we call Barrett's esophagus. What is Barrett's esophagus? The scientific term for it is intestinal metaplasia. Intestinal metaplasia is essentially when one cell line changes into another cell line. So in this case, what's happening is that the esophagus cells are turning into stomach cells. Why are they doing it? They're doing it because we're not supposed to have acid in the esophagus, as Dr. Woodworth explained to you guys. So stomach cells are naturally created in a way to withstand the pressures of acidity. So if you think about it, in our human body, there's one area that has very high acidity. And we all know that acid burns, it's caustic, it causes badness. So our stomach has to be designed in a way to withstand that pressure. So stomach cells are very unique when it comes to that. Esophagus cells are completely different. They look different, they cannot withstand those pressures of the acidity. So you can imagine if someone continues to have acid reflux year after year after year, the esophagus is going to get damaged, but it gets smart. Those cells actually start morphing. They start changing themselves to look and become essentially stomach cells. So the esophagus cells think they're doing something good. They're going to kind of a self-protection mode, a self-preservation mode. The problem in human biology is we do not like it when cells have a mind of their own. We do not like it when cells change. And so that first change of mimicking a stomach cell is called metaplasia, more commonly known as Barrett's esophagus. Barrett's esophagus is a precancer condition, and that's illustrated in the second slide right here. So what we didn't talk about a little bit earlier today, and I'm going to expound on, is the term dysplasia. So we know that Barrett's esophagus is a precancer condition. It can turn into cancer, which is over here. There's an intermediate step, however. So from Barrett's esophagus, we can get Barrett's esophagus with dysplasia. Dysplasia is not just the mimicking of the cell, not just changing from one cell type to another. It's when you actually are getting molecular changes now within those cells. That's bad news bears, is what I say to my patients. Because your risk of getting esophagus cancer here, while it's high, it's still overall low, but it is high to multiple magnitudes compared to average risk patients. When you get to this point here and have dysplasia, your risk of getting esophagus cancer jumps significantly. This is scary. These are the patients that we need to send and go do additional interventions. And we alluded to that earlier. It's ablating them, burning them is what we call it, and sometimes actually cutting out the tissue in that area to definitively remove it. That's how scary this is, because these are the patients who will really go on to this really rapidly. So this is why it's so important that we catch patients here. And really, this has revolutionized the way that we practice GI, because we have not had a way to, in a minimally invasive way, capture patients here. Once we capture them here, we know everything to do to prevent them from going over here. We have all the tools. That's what I'm proud to say. In the GI world, we have the evidence, we have the management tools, we have the meds, and how Dr. Woodworth explained to you, we have the surgeries that can definitively prevent you from going from here to here or from here to here. So 2 years ago, when someone walked into my office and said, we have the technology in a minimally invasive way to identify patients here, it was a no-brainer. I said, great. If I can find out my patients and who has this, I take care of the rest. I already got all the tools. Once I know they're here, they will never get cancer. And in fact, in my career, I have never diagnosed esophagus cancer in any patient who I've diagnosed appropriately with Barrett's esophagus. Why? Because we can prevent it. However, I have diagnosed esophagus cancer in patients, and almost always it's in patients who were never told they had Barrett's. That's unfortunate, and that's what we're here to prevent. Here's the statistic. You already saw it once. So 733% increase over the past 4 decades. We're doing something wrong, or we were doing something wrong, I should say. So it doesn't really make sense. I just explained to you guys that we have an identifiable risk factor for esophagus cancer. I also finished telling you that we have the tools to prevent esophagus cancer when Barrett's is identified. So then why would we have a 733% increase? There's only one answer. We're not identifying Barrett's. We're not identifying it in the right patients. We're not identifying the right risk factors, and we didn't have the tools to screen and identify Barrett's. That's the unmet need, which has now been filled. Some more statistics before we start talking about the test. So we know the 733% increase. These are the reasons why, as I explained, why this is happening. We're not screening patients. We're not identifying them. We don't understand the risk factors. And more importantly, we didn't have the tools to really screen them in a minimally invasive way. As Dr. Woodworth explained to you guys, this is a very bad outcome. So we have a cancer that when we diagnose it has a very high morbidity, very high mortality. 80% of patients die within 5 years. All of these patients were preventable had they had been diagnosed with Barrett's. And as I mentioned, I can't stress this enough, we know how to prevent cancer as long as the Barrett's is diagnosed. We just have to diagnose the Barrett's. So we have EsoGuard. We're going to compare it to the Pap smear here. So I can confidently affirm and attest to the fact that the advent of EsoGuard is a complete milestone in the GI field. It is basically the same as the advent of the Pap smear. We heard the other physicians earlier talking about that. Cervical cancer has a precancerous lesion that is identifiable. Once that identifiable precancerous lesion is identified, we have the tools to prevent cervical cancer. That's why Pap smears are so common. Because 30, 40, actually probably about 50 years ago, we were having the same discussion then. We were saying, we know what the identifiable precancerous lesion is in cervical cancer, but our cervical cancers are on the rise. What's the misconnect here? And the misconnect then was that we didn't have a way to identify those precancerous cells. But then there was the advent of the Pap smear. It was then refined. We have the thin prep, and you know the rest of that story. And so we're now at the beginning of this milestone. So it has completely changed what we do in GI. A little bit about the test itself and the applicability and my own experience with it in the office. First of all, it's a swallowable balloon. It's inflatable. It starts here in the deflated state. The patient swallows it. It's connected to a catheter. After they swallow it, it goes into the stomach, past that sphincter that Dr. Woodworth was telling you guys about between the esophagus and the stomach. Once it's inside the stomach, it's inflated. After it's inflated, it's pulled back, and it stops right at that valve. As it's pulled through the valve, it will collect cells through the chevrons that are around the balloon. Once it's inside the esophagus and the cells have been collected, it's deflated and then withdrawn. Door to door, in my experience, 5 minutes. Mouth to outside, 1 minute. So we have nurse practitioners that come to my office. They're very well trained. I always tell patients what to expect. I say, you have a really well trained nurse practitioner that just basically does this all day, every day. It goes down like butter, comes down within 1 minute, and you get a potentially life-saving test done for you. Once we get those results, if it's a positive test, we will schedule you for an endoscopy. And so the nice thing, and I'll talk to you more about this in a second, is that we have a testing center inside my office. So it's a very streamlined process. I identify patients who need the test, we order it, nurse practitioner comes to our office, does it, and then we look at the results a few weeks later and they get an endoscopy if it's positive. So as I mentioned, this is a milestone. I can attest to that, I can affirm it. Up until now, in the world of GI, we have been diagnosing multiple cancers, and unfortunately, very bad ones. If you think about it, we have esophagus cancer, liver cancer, stomach cancer, pancreatic cancer, biliary cancer, including gallbladder, colon cancer, and in rare circumstances, small intestinal cancer. And for the clinicians in the room, they will agree with me that they're all terrible. And up until 2 years ago, I was only able to screen for one of them. Very sad statistic. And we put all of our energy into that, colon cancer screening, which is great. You can now see the outcome when it comes to it. If I went back to that slide, you would see that the numbers for colon cancer have plateaued. Beautiful, we're doing a great job of it. But what about all the other terrible cancers? It's really hard when I have to diagnose someone with pancreatic cancer. I will tell you, almost exclusively, it's someone not old. It's middle-aged for some reason, children, no symptoms, sometimes, often with symptoms. When they have symptoms, that's when you know it's bad, because it's usually stage 3, stage 4, they have a very bad prognosis. Esophagus cancer, same thing. So finally, we have a way to identify the known precancer lesion and literally put in what we need to put in place to prevent that. What are those things that I do? Medicines. So proton pump inhibitors is what we give patients. We have proven data that shows that proton pump inhibitors decrease the rate of progression from those steps that I showed you earlier. And we do endoscopy surveillance. So for those of you who've had colonoscopies or know someone who've had it, you know that if you've had a polyp, then your doctor will tell you return in X amount of years because you have shown and declared yourself as somebody who has polyps and is high risk for developing colon cancer. So you need to go into a surveillance program and get your colonoscopy at X amount of years. We do the exact same thing for patients who have Barrett's. They have to get endoscopies rather between 1, 3, and 5 years, depending on where they are on the surveillance program. But essentially, we know what prevents the esophagus cancer development. It's the starting of medications and getting the appropriate endoscopies in the appropriate time intervals. And as long as patients get those two things, they will not get esophagus cancer. And as I mentioned, I've never had a patient of mine who's had Barrett's go on to get esophagus cancer. So the point is to diagnose them with Barrett's. So our role as clinicians within Lucid and with EsoGuard. So as I mentioned, there's multiple ways I'm part of this network, which is great. It just exemplifies the support and the infrastructure in Lucid and with EsoGuard. So it all started 2 years ago when a representative came to my office and talked to me about EsoCheck and EsoGuard. That was the day where it was a no-brainer for me. I said, yes, I'm all about preventive care. I spend a lot of times talking to my patients about prevention. So when they said that there's a way to now identify Barrett's, I said, this is revolutionary, because up until now, I only had one tool. That tool was endoscopy. And endoscopy I can only do in a certain subset of my patients. I knew that I was practicing a type of medicine that had a huge population of patients that I was overlooking. Not because I wanted to, but because we didn't have the tool. So a lovely lady walked in, her name is Erica. She came in, she talked to me about EsoGuard, and I immediately clicked and I said, yes, this is what GI has required. And ever since then, I've been using it to test my patients who I otherwise would not be doing endoscopy on, but have risk for Barrett's esophagus. So of course, the first way that I'm part of the community is by implementing the test and having my patients get the test. Support. So I have huge support from this company. I've actually never really seen this much support from one company trying to really support my practice, support my patients, support my staff. I'm very busy. We're all very busy. So if I had to sit there and educate my medical assistants, educate my patients, schedule patients, figure out access to the test, I wouldn't have enough hours in the day. Lucid does it all for me. So their reps are incredible. I've never met an unhappy, non-productive, non-helpful rep. The reps are incredible. I text them, they get me what I need. Literally a few weeks ago, I texted our local rep and I said, I need the paperwork in Spanish, the little pamphlets that we have with Freddie on them. I said, do you have this in Spanish? She texted me back within 10 minutes, I'm gonna deliver them tomorrow. Tomorrow, we had Spanish-speaking pamphlets in my office. So the staff support is really great. Getting results, we talk to the reps, they help us get results. When we want to get access and figure out coverage and things like that, incredible support. So implementing it makes this easier when you have this type of support within the company. I'm fortunate enough and privileged enough to be a speaker on a speaker bureau for EsoGuard. I have loved it because, first of all, I hope you can sense my passion in my voice when it comes to this test and how it changes my practice. But I love sending the message out to my colleagues. And I have to say, as I do different programs and I talk to colleagues, peers that are gastroenterologists, peers who are internists and family practitioners, and others who are mid-level nurse practitioners and PAs, the reception has been incredible. It really has been, like it was for me, a no-brainer. Like, yes, this has been an unmet need that finally we have a tool on. Sometimes when it comes to the world of GI, I have to explain a little bit more as to why it's not, as Sean was talking about earlier, like taking away from our scopes. And I'm going to present a case at the end of today's presentation that exemplifies why it doesn't actually take away from our scopes. And in fact, it actually adds to my scopes in my business. So that's been a little bit of a challenge. But once you talk about the technology and talk about the data, it speaks for itself. And the reception has been overall great. And then finally is testing. So a test is great if you have it, but you need access to it, right? And so in this short amount of 2 years, I've really seen the growth when it comes to access. Every time I travel to another city to give a talk, I always ask the local representative, does the practice I'm gonna go talk to, do they even have a testing center? And 100% they've said, oh yeah, we already have a testing center set up for them. So I'm one of those testing centers in my community. So we have nurse practitioners come to my office and we do testing there, which makes it really streamlined. But in other communities, there's actual satellite clinics that patients can go to. The bottom line is that they've really created this network and really looked at the geography to make sure that, one, patients who want the test can get the test, and two, that it's easy for them to do it. It's already a fast test, so let's make them at least not have to drive an hour or 2 hours to go get the test, and it's all streamlined that way. So that's my network when it comes to Lucid, and putting this all together has really allowed me to deliver better healthcare. I really elevated my practice, and as I mentioned earlier, it's made me even more busy. Sometimes that's a drawback, but it's made me even more busy than I was before, but it's all for good cause and for healthcare. So as promised, I wanted to explain or go over a case series. I think this is I call it a poster child for EsoGuard and how on the front lines it really changes our practice and how it's changed my practice. So here we have a patient who came to see me simply for colon cancer screening. That's why he came in. Young man, really no medical history, no family history. Chief complaint, I'm here because my doctor told me I need to get a colonoscopy for my colon cancer screening. So, as usual, what I do is I go through risk factors for my patients. So I go through a review systems and I talk to them about these things. Some of those things I elicit from a patient. Some of those things are demographic information that I can easily get from the chart. Age, gender, weight, etc. So I went through it, and he did mention that he gets occasional reflux. But if Dr. Woodworth would be with me, he would also agree that the type of reflux he was describing was not pathologic. So it was that type of reflux that we would expect. Once in a blue moon, after a spicy meal, after pizza. And in GI, we don't really consider that GERD. We consider that regular acid reflux because of dietary and very minimal. So he did not have what we would call GERD. However, he had 3 other risk factors. The guidelines were presented to you earlier today, and one of those guidelines is put forth by the AGA. The AGA says, and this is really remarkable that they've actually changed their stance, is that GERD does not have to be a prerequisite risk factor. It is one of the several risk factors for GERD. And as long as the patient has 3 or more of those risk factors, they are at risk for Barrett's, and we may consider screening them. You can screen them with all of the tools we had. And Sean was saying that they even showed the little capsule for the ACG guidelines. So the AGA also discusses EsoCheck as well too. And so it's an appropriate way to screen those patients. So back to our patient. Male, white, obese. That's it. 3 risk factors. So at the end of the talk, when I talked to him as colon cancer screening and colonoscopy, I said to him, you also have 3 risk factors for another condition. It's a pre-cancer condition in your esophagus. So you need to get screened for that too. First and foremost, I will say he was very appreciative, and I get that very often. Patients love it when they come in for one thing, and they're educated and informed that they're at risk for something else, especially silent disease. So it builds a bond between me and the patient that becomes stronger. It adds to my credibility, and they know I'm taking good care of them. I'm not just looking at tunnel vision. I know you came in for one thing, and that's the only thing I'm going to think about today. They know that I'm thinking about them as a whole. Then they're very appreciative. So he went on, oh, sorry about that. So he went on to get the EsoGuard. He did EsoGuard, and sure enough, it came back positive. Came back positive, I called the patient. I called the patient, I said, you know that swallowing test that you did? It was positive. He asked me, what does that mean? I said, right now, we know that the test is picking up on some sort of changes in your esophagus. We don't know what it means exactly. We need to confirm it. What do we confirm it with? An endoscopy. So we scheduled you for a colonoscopy next month. We're also going to do an endoscopy at the same time. So this is a patient that went from getting one procedure with me to now getting 2 procedures with me. He accepted and we moved on. I did an endoscopy shortly after. Visually, I saw Barrett's. So when I woke him up that morning, I told him, that test that we saw that was positive, I think it does signify this condition called Barrett's. But we have to wait for biopsies to come back and to confirm it, and I'll call you when I get those results. But I will tell you that visually, I think you have this condition. We got the biopsy results back. He had Barrett's esophagus. So I've already had the discussion with him, and I've already met with him in the office. We had a post-procedure follow-up a few weeks ago. I explained to him what Barrett's is. I explained to him everything I explained to you guys in the beginning in the presentation. I talked to him about his risk. I calmed him. I let him know that while he has a higher risk than other people, overall it's a low risk. And as long as he takes the right medicine and does the right endoscopies at the right intervals, there's no reason I will ever allow him to get esophagus cancer. And I say that with conviction when I tell my patients that. As long as they continue their follow-up and take their medications, it puts them at ease. The patient was started on medication, and he's going to get another endoscopy by me in 1 year. So this entire case presentation completely exemplifies why we're here today. We identified a patient simply based off of risk factors that in this case had nothing to do with reflux, but didn't change the fact that he had Barrett's. We ordered the test, it was positive, and we changed the medical decision here. Not only did he get a new diagnosis, one that's silent but has significant implications, but he's now going to start into a protocol with medications and endoscopies. From me as a clinician, I feel fulfilled. I really truly feel like we prevented a death, a potential death. As a gastroenterologist, I will say I don't think I save lives. I think there are other more important doctors than me that actually save lives day to day, but at least I can say that I probably prevented a potential death by doing that, and the patient did the right thing by doing the test as well too. Incidentally, I should say, this case is very interesting because if you look here, on that endoscopy, I diagnosed 2 other silent conditions with significant implication. The patient had H. pylori. It's an infection. It's known as it's a class 1 carcinogen. So much like HPV, which is a virus that we know causes cervical cancer, throat cancer, rectal cancer, H. pylori is a class 1 carcinogen. It's an infection we get when we're children. It usually sits in your stomach. About 20% of the population has it. And it's generally silent in most patients. However, it can cause ulcers and cancer. So it's silent until it's no longer silent. So we identified that in the stomach. He is currently getting the treatment to eradicate that. Again, another potentially life-saving diagnosis. He also had a tumor in the lining of his stomach. These were completely incidental. And I don't want to stand here and say that EsoGuard identified these. We know it doesn't do these, but it is interesting to know the domino effect that this had here. And this patient truly did save their own life by doing the EsoGuard and agreeing to do it based off of those risk factors. So without EsoGuard, this patient would have been left with multiple silent, undiagnosed diseases and come back later in life either with trouble swallowing food, with stomach cancer, or other kinds of bad things. And had he not gotten EsoGuard, he would have never found those very 2 severe conditions. So that ends my presentation. Hopefully I was able to kind of illustrate how I use EsoGuard and how it's really changed my practice as a gastroenterologist, kind of at the front line of this. I think that there's a misconception about it taking away procedures. Here I already showed you a patient who actually added to my procedures. I asked my office manager just yesterday to give me a rundown of the number of tests we did in the last 6 weeks. In the last 6 weeks, we did 17 tests in my office, 7 were positive for EsoGuard. That's just above 40% positivity rate. Those are 7 patients that I am now going to do endoscopies on that otherwise would not have gone endoscopy by me. So it doesn't take away from our procedures, it adds to my procedures. But the more important message here is that it's enhancing my healthcare and what I'm delivering. I'm identifying patients who had an otherwise silent condition and otherwise would not have been identified because they weren't a candidate to get an endoscopy, and then we're later identifying them and putting them in the right treatment protocols and the right surveillance programs. So that was a great case to have a few weeks ago. I thought it would be perfect to share today. And so that's my network and my connection to Lucid, and thank you for your time.